In this lecture series, we're going to talk about cardiac-specific diseases. These lectures are for EMS 241, Paramedic Cardiac Management. To start with, we're going to discuss pharmacological management. These are going to be just a few of the drugs that are used to treat cardiac illness. To start with, we'll talk about atropine sulfate. So atropine is a parasympatholytic agent used to treat symptomatic bradycardias. Our dosage on atropine is 1 milligram IV, and you can repeat it for a total dose of 3 milligrams. Another term for parasympatholytic is anticholinergic. So essentially, atropine works by blocking acetylcholine at the SA node that is produced by the vagal nerve. Adenosine. Adenosine is used for stable narrow complex tachycardias, SVTs, unstable narrow complex tachycardias while preparations are being made for electrical cardioversion, stable regular monomorphic wide complex tachycardias, both therapeutic and diagnostic maneuver. Our dosage for adenosine is going to be 6 milligrams initially, rapid IV push. Remember, it has a short half-life. Then we're going to follow that with 20 milliliter flush. Then we can use a second dose if it's refractory to the first dose for 12 milligrams rapid IV push with a 20 milliliter flush. Amiodarone, may also be called Cordarone, is an antiarrhythmic agent. It's a class 3 antiarrhythmic agent used in cardiac arrest with shockable rhythms, atrial fibrillation, stable narrow complex tachycardias. Also, it is used in wide complex tachycardias with a pulse. We use this to control rapid ventricular rate and also to depolarize. Our dosage for cardiac arrest is 300 milligrams IV push, followed by 150 milligrams IV push. And for tachycardias with a pulse, would be 150 milligrams over 10 minutes. Diltiazem, or Cardiazem, is a calcium channel blocker. It slows heart rate in supraventricular tachycardias, used for stable narrow complex tachycardias if the rhythm remains uncontrolled or unconverted. Control of ventricular rate in patients with AFib or atrial flutter. The typical standard accepted dose of diltiazem is 0.25 milligrams per kilogram. Moving on to vasopressors. Vasopressor agents constrict blood vessels. Most of them are sympathomimetics, such as epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, and vasopressin. Epinephrine is a non-selective adrenergic agonist. It acts on alpha and beta adrenergic receptors. It is a mainstay for cardiac arrest resuscitation. Norepinephrine is a sympathomimetic with alpha agonist properties greater than those of epinephrine. Dopamine is a vasopressor, and it increases cardiac output, and it stimulates both alpha and beta receptors. Dobutamine increases cardiac output by increasing stroke volume. It has little effect on heart rate. And then vasopressin is a naturally occurring hormone called antidiuretic hormone secreted by pituitary glands, and it will have sympathomimetic effects. Oxygen is a drug, and it can cause vasoconstriction. It aids in oxygenation of the peripheral tissues. If the patient's SpO2 doesn't require oxygen, use your clinical judgment before administering. Nitrous oxide is an analgesic with no significant hemodynamic effects. It is delivered in a fixed combination of 50% oxygen and 50% nitro or nitrous oxide, and can increase the myocardial oxygen supply. Nitroglycerin is a mainstay for acute coronary syndrome. It's an organic nitrate. It dilates peripheral arteries and veins, reducing preload, afterload, and myocardial oxygen demand. It loses potency as soon as the bottle is opened. Morphine, an opiate narcotic. It reduces myocardial oxygen demand by reducing preload and afterload, and it also will cause analgesic effects as well. Fentanyl is a synthetic opiate analgesic, and it's chemically unrelated to morphine. It has shorter acting properties, and it also has a better side effect profile. Aspirin is not a fibrinolytic, but it plays a role in treatment of cardiac ischemia. It inhibits aggregation of platelets, and it is effective in treatment of coronary ischemia and stroke. Definitive treatment of myocardial ischemia is going to be fibrinolytic agents such as alteplase or tenecteplase. Some other drugs: Lasix or furosemide is a potent loop diuretic that relaxes the venous system, often used to help reduce blood pressure or to get excessive fluid off the body. Diazepam or lorazepam, a benzodiazepine, if a patient is apprehensive or agitated. And then Zofran. Many times when somebody has ACS, they experience nausea and vomiting, so Zofran would be something that you would want to consider giving. Take a moment and look at this chart that I've provided here. It gives you some very good information as far as the drugs and where they act. For like sinus bradycardia, you'll see that it works to block acetylcholine at the SA node. For ventricular and supraventricular drugs, you got amiodarone and sotalol for class 3 antiarrhythmics, class 1A procainamide or disopyramide. And if you notice here, these will work. Class 1A works on phase 0 rapid sodium channels, and amiodarone slows phase 0 and 3. Adenosine works at the AV node to slow AV nodal conduction. Verapamil is another calcium channel blocker. Digoxin is a cardioglycoside, and all of these work at the AV node. Also, it may work to inhibit the calcium channels. Beta blockers work against the beta receptors. These include your LAL drugs, propranolol, atenolol, or sotalol. This concludes a quick review of the cardiac medications for EMS 241. We will have a more in-depth review later on in this class. Our next up will be part 2, electrical therapy.